Okay, good afternoon once again. Welcome to our topic on antidepressants. We said antidepressants are a class of medications that are used to treat major depressive disorders. That means we have minor and also major depressive disorders. We shall see some few examples of these categories. So we have the major depressive disorders. We also have the anxiety disorders, which are actually could be minor. Sometimes these same drugs are also used in the treatment of chronic pain and also addiction. Nevertheless, these drugs also have some common side effects, which include sometimes dry mouth, weight gain, dizziness, headaches, akathisia. This is like restlessness, sexual dysfunction, and also emotional blunting. For major depression, uh, we have the category of the severe biological illness. We say it's not a character flaw or unstable personality. Most common psychiatric disorder, which affects like 30% of people during their lifetime. This is the major depression prevalence. Also, 5% of the adult population are depressed at any given time. There is high disability because it really causes people with major depression are already disabled in such a way that their cognitive function is impaired. They can't function for themselves. They need the help of others. Okay, here it is comparable to heart disease and also stroke as the other most common causes of disability. It is a chronic condition. All major depressive illnesses are chronic conditions, often requiring long-term treatment. It also occurs with gender difference. The incidence is 2 times higher in females than in men. They are also characterized by high suicide risk. 80% of those who commit suicide are actually men. Underdiagnosed and untreated. Many of these diseases are always underdiagnosed and also undertreated. Only 30% receive proper treatment. There are remission rates and about 40% experience full remission. So like after getting recovery, still the person can become sick again and yeah, he remits back into the sickness. So that means more prolonged treatment might be needed and sometimes the compliance may not be as easy as we can achieve. At 20 to 30% experience partial remission. We look at the clinical features, they are always depressed with persistent feelings of sadness. They always lack interest in pleasurable activities, okay, lack of enjoyment activities that once they normally enjoy. There is weight and appetite changes. Many of these people, you find one of the symptoms actually is that they decide not to eat. They stay and lose appetite, and the mind is preoccupied, and all of a sudden, there is no interest in food. With significant weight gain, sometimes or weight loss, with changes in appetite. Also, they have sleep disturbance like insomnia or hypersomnia. Okay, it could be excessive sleep or even inadequate sleep. Psychomotor changes, they have agitation and also retardation in movements, fatigue and loss of energy with persistent tiredness and also lack of energy. Still continuing with the clinical features, they also have feeling of worthlessness. They feel like they are not important, okay? Excessive or inappropriate guilt. They may just talk things that you don't understand, that some people are looking for them, maybe the policemen are looking for them, all those kind of categories. Just feeling guilty, but with hallucinations, talking things that you don't see, you don't feel, and you don't understand, but it is real in their mind. There is cognitive impairment with decreased ability to think. They cannot concentrate first of all, they are restless or cannot make decisions because the mind is preoccupied with inner thoughts. And most of those inner thoughts are linked to suicidal thoughts because they feel worthlessness with all the guilt they feel and recurrent thoughts of death, and that's why suicides are very common in people with mental sickness. Common features of depression, they always have sleep disturbance, appetite changes, depressed mood, and hedonia, which means lack of interest in pleasurable activities that they used to enjoy previously. There's also fatigue, and then there's agitation and also depression. Concentration difficulties, low self-esteem, okay, feeling worthless, and then suicidal thoughts. Causes, what is the etiology? It's complex and not fully understood. It is multifactorial. We don't understand all the factors. But we said many factors contribute to depression. They can be triggered by stress, brought on by stressful life events. Also, biological explanation has been used. And this is normally in line with genetic vulnerability, like people with a family line history. So it's that kind of genetic uh, vulnerability to the disease if maybe previous people line of the family had the same disease. There is also a risk that it can happen in the siblings. There is another hypothesis relating to monoamine hypothesis, previously believed to be due to neurotransmitter deficiencies. So we talk about the monoamine oxidase inhibitors. We talked about the neurotransmitter in the brain. So there was the hypothesis which says that perhaps some people have a deficiency of these neurotransmitters that predisposes them to the effects of depression, such as serotonin, norepinephrine, but it has now been recognized as as a more complex treatment. We said there are three major modalities. We use pharmacotherapy and other somatic therapies and also psychotherapy. So it's drug therapy, we have the somatic therapy and also psychological therapy. Pharmacotherapy is a medication-based treatment. The other somatic therapy is the non-drug treatment, like what we call the electroconvulsive therapy. It's not commonly used these days, but always the pharmacotherapy should be followed with psychotherapy, which is counseling and talking to these people. Mild or moderate depression, we use drug therapy or psychotherapy. The response time might be slow response with initial effects in 1 to 3 weeks and maximal effects sometimes in 1 to 2 months. Duration of treatment should normally be continued for almost 6 to 23 months, almost 2 years, or can be lifelong if it is recurrent. Let's look at depression in pregnancy. There is what we call baby blues. This one refers to mild and transient mood changes that occurs following delivery. Normal and does not, it is said to be normal and does not really require treatment. Okay, it's what we call postpartum blues. Sometimes it occurs in women after getting pregnant and giving birth. This peripartum depression affects 1 out of 8 women and it occurs shortly before even after giving birth. Sometimes it can worsen without treatment and can become detrimental to the mother and the child. We also have what we call postpartum psychosis. It's a bit rare, but it's a serious condition if it happens with a lot of disorders and hallucination, and it's actually a medical emergency. Let's look at the antidepressant medications used for managing these depressive illnesses. The most commonly used is what we call the tricyclic antidepressants, TCAs. The early antidepressants that block the reuptake of serotonin and norepinephrine have many side effects and risks. There's what we call the SSRIs, selective serotonin reuptake. We said serotonin is one of the neurotransmitters that is involved in the treatment of depression, the depressive illness. Okay, this was introduced in 1987 as effective uh, antitricyclic antidepressant, but with few side effects and used for various conditions beyond depression. Next in the line, we have the monoamine oxidase inhibitors. They block enzymes that break down the neurotransmitters used for treatment of resistant depression, but have also some dietary restrictions. Suicide risk with antidepressants, early treatment, there may be thought of suicide, which might increase during the early treatment. Observation and patients should be closely observed for signs of suicidal thinking and mood. So when we are giving this treatment, we should always monitor the closely to avoid the occurrence of these incidences. Again, there's a controversy in the link between suicide and antidepressant remains controversial, but warnings are included on all the drugs due to possibility of increases. So sometimes some patients commit suicide when they're already taking this medication, and it becomes difficult to know, like, is it really the medication again that is causing the suicide, or they are just committing the suicide because already of the known effect of the depression, which we said many people, even not on medication, also commit suicide because of the nature of thoughts that this particular disease gives them. So it becomes a bit controversial. We look at the non-conventional drugs. We have NMDA antagonists, or we call them glutamatergic agents like ketamine or other drugs with rapid onset antidepressant effects are also being used. We have monoclonal antibodies that targets the immune system signaling, like the one called sirukamab. We have anti-inflammatory agents like the non-steroidal anti-inflammatory drugs and the omega-3 fatty acids and the cytokine antagonists. We have opioids drugs like buprenorphine as a fatty opioid receptor agonist. Then we have the over-the-counter herbal products such as the Santijo's word for mild to moderate depression that we looked at in the previous lecture. Still with the somatic non-drug treatment, we look at the electroshock or the electroconvulsive therapy. It's effective for severe depression or treatment-resistant cases. Transcranial magnetic stimulation, pulse magnetic fields to the forehead for several weeks. Vagus nerve stimulation is used for treatment-resistant depression and also epilepsy. A brain light exposure therapy is beneficial for seasonal affective disorder and non-seasonal depression, and can also be used alone or in combination with other antidepressants. We have come to the end of this session, so thank you so much for being with me, and bye for now.